We go now to Dr. Juwairia, Vice President of American Society, and Dr. speak to us about management of heart failure across ejection fractions.
So I've been tasked with a very difficult task. Usually heart failure is presented over 2 days conference, and I'm supposed to finish it in 15 minutes. So I'm just gonna give you major highlights in the management of heart failure. But first of all, let's remember what's the burden of heart failure. About 21 million patients are living with heart failure worldwide, and this number is expected to increase as the population ages. It's a huge economic burden. So around in the year 2012, the overall cost of heart failure was $108 billion. And it carries a very high mortality. So from diagnosis and up to 5 years from diagnosis, half of the patients will die. So you're losing half of the patients in 5 years, and that's a major mortality. It's a major cause of rehospitalization, and it's the #1 cause of hospitalization in patients above the age of 65. And usually heart failure patients has lots of comorbidities, at least 3 or more comorbidities. So you know what heart failure is. It's an abnormality of the cardiac structure and function that leads to failure to the heart to deliver oxygen at a rate that meets the requirements of the metabolizing tissues, despite normal filling pressures. And you've heard a lot of terminologies of how to classify heart failure, either related to ejection fraction, related to the time course, whether it's acute or chronic, or related to progression, whether it's worsening or stable, and related to the location. But why do we keep emphasizing ejection fraction? So this is what we're talking about. On the left side, you have a dilated heart with a reduced ejection fraction. And on the right side of the screen, you have a small LV cavity, thick ventricle, and a normal ejection fraction. And generally, what's been mentioned in the literature is half of your patients will be on this side and the other half will be on the other side. But as we know right now, most of the patients are shifted towards the right side of the screen. So that we're seeing more and more preserved ejection fraction because we're able to diagnose them better. It's always important to look for the etiology of heart failure when you have someone with de novo heart failure. And at the top of the screen, as it should be the top of your diagnosis, is myocardial disease. So you need to look for coronary artery disease, hypertension, and cardiomyopathies. But then rule all the other etiologies as well. So you have valvular heart disease, pericardial disease, which can be easily diagnosed by echo. Presence of high output states, which requires you to take a little bit of history and look at the investigations appropriately. Presence of volume overload conditions in case of renal failure, or in case of something that we actually did to the patient, where we give them more fluids intraoperatively or postoperatively. Congenital heart disease, usually you diagnose them as well by echo. Presence of arrhythmias, either tachy or bradyarrhythmias, and then looking for endocardial disease, which is a little bit rare on the list, but it's one of the things that you can pick up on echo. Why do we care about ejection fraction? Because it carries different mortality. So patients with reduced ejection fraction have worse all-cause mortality, worse cardiovascular and heart failure deaths, where patients with reserved ejection fraction have actually worse non-cardiovascular death, and that's a translation of the risk factors because they have lots of comorbidities. And patients in the mid-range of ejection fraction would have the lowest overall risk. So a short history of where did we come up with ejection fraction. So in the 1980s, there was mention of heart failure as a clinical syndrome. There was no mention of ejection fraction. And as we move forward through the years, with lots of trials coming up in the 1990s, we started to talk about heart failure with reduced ejection fraction and talking about ejection fractions of less than 35 or less than 40, depending on which study you're looking at. And then we reached to around to the year of 2000, where you have patients with preserved ejection fraction. So now we classified whoever that's not reduced ejection fraction to be a preserved ejection fraction. And then more studies came up. And then around the year of 2013, we decided that not all of them are the same. We have lots of evidence for patients with ejection fraction less than 35. We do not have much evidence for the patients in the middle range, so between 40 and 50. And then we have a different clinical entity with an ejection fraction more than 50. So we defined this group of borderline ejection fraction. And then in 2017, we changed our mind again, and we called the the borderline ejection fraction mid-range ejection fraction, because we don't think these are borderline. We know that there is a cardiovascular abnormality going on right now, but it's not that severe, so we called it mid-range. And we keep on changing our time. So ejection fraction seems to be a moving target with heart failure. And as it changes, we change our terminology and we change our recommendation. And this is what's recommended right now, is to move away from saying preserved and reduced, because we think that all patients with abnormal ejection fraction do as bad. And the effect of therapy can be seen up to ejection fraction of normal, which is different for men and women. So for men, it's around 50 to 55, and for women, it's up to 60. So anything above that is someone with preserved ejection fraction, but we might change our mind again. So keep reading cardiology literature. So why do we keep dividing these patients? Because all our recommendation is actually for patients with reduced ejection fraction. All the guidelines are for this, and all the class 1 recommendations is here. Patients with preserved ejection fraction, we don't have a lot of recommendations. We have specific therapies for specific diseases, so for cardiac amyloidosis or hypertrophic cardiomyopathy. And then we have the group in the mid-range where we are not 100% sure, but we think all the medical therapies that apply to reduce ejection fraction will have benefit in this group. So this group in the middle used to have no recommendation before in the guidelines, and currently they have class 2 recommendation for these therapies in the mid-range. So this is the latest guidelines from the European Society of Cardiology 2021. And there was some changes in the management that I'd like to highlight to you. So when starting with the therapy, it's important to have the patients on the 4 pillars of heart failure therapy, which is ACE inhibitors or ARNI. ARNI is sacubitril valsartan, beta blockers, MRAs, and an Sglt2 inhibitor, a dapagliflozin or an empagliflozin. And that's regardless of the status, whether the patient is diabetic or not. And then a loop diuretic will be added if there is fluid retention. And this is a class 1 recommendation. So all heart failure patients with reduced ejection fraction should be on all these 4 medications. And the recommendation does not suggest a specific order. You just have to have them on these medication or whatever order you decide on. And then after you've done that, then you can evaluate for devices. So if the ejection fraction remains low, less than 35%, and the QRS duration is short, then this patient should be evaluated for an ICD, depending on the etiology of the heart failure. If the QRS is long, more than 130, then you evaluate this patient for cardiac resynchronization therapy. And if the ejection fraction is more than 35 and the patient is still symptomatic, then you can go for the class 2 recommendations for treatment of heart failure. So always remember the 4 pillars. If you're not gonna remember anything, remember this from my talk. You need to have the patients on these 4 medications: an ACE inhibitor or an ARNI, beta blockers, MRAs, and an Sglt2 inhibitor as soon as possible from the diagnosis, and they have to be on all of them. So all these medications, why all of them? Because all of these medications reduce mortality in patients with heart failure. After you're done with these medications, you can go for the class 2 medications, and generally they are basically a control of heart rate in patients with ivabradine, and in patients with black race to use hydralazine and isosorbide dinitrate. Okay, so I'm sure you've heard a lot about Sglt2 inhibitor over the past year. Everybody was surprised why this medication works. Nobody knows for sure why it works in heart failure. It's not related to just diuresis. That's what people thought at the beginning, because we don't see this benefit with diuretics. We only see it with Sglt2 inhibitor. But if you see Emperor Reduce and DAPA-HF, these 2 trials showed improved first hospitalization of heart failure and cardiovascular death in patients taking these medications. And why do we need to add medications? Because the more you add medications, you're adding lives to the patient. So if you start with 2 therapies, your odds ratio of death is 0.6. But as you add more therapies, you actually can halve the risk of death within 2 years. And we're talking about 2 years, not 5 years here. Imagine, we're talking about a disease that gives mortality of 50% at 5 years. So this is very important to be done. And if you look at which medication you use, so if you start with a beta blocker, you get around 40% reduction of death. If you add an ACE and an ARB, you get around 60%. You add an ICD, you get to somewhere between around 75%. So the more you add therapy, the better the outcome for the patient. Okay, so there is no recommendation on sequence of the medication. You can choose whatever you want, and you can decide based on the patient's unique circumstances. So what's their blood pressure, what's their heart rate, what's their renal function, but you have to do it as soon as possible and as fast as possible and as safely as possible. So how can you make your decision if the guidelines is not telling you? So there's a consensus statement from the Heart Failure Association of the European Society that came almost a month before the guidelines. This is a very important paper that I encourage you all to read. It tells you how to manage each different patient profile accordingly. And it divides patients according to their blood pressure, their heart rate, their kidney function, the presence of absence of atrial fibrillation, and their volume status to these 9 different profiles. So, and it gives specific recommendation in each profile on how to manage their medication, which medication to start first, which medication to not escalate maybe at this moment. And the patient can move from one profile to another. They can start with a low blood pressure, but then they have a normal blood pressure, and then you change your management according to the profile. So that's why treatment of heart failure is very dynamic and requires following up the patient and making sure that you're treating them appropriately. And there is this concept of heart failure spending function. You have certain amount of reserve with the patient in terms of blood pressure, heart rate, kidney function, potassium, and cost of medication. And you're trying to balance this with the choice of medication that you use. So maybe you're not gonna use something that will lower the blood pressure a lot in someone with a low blood pressure. So Sglt2 inhibitors and beta blockers do not affect the blood pressure that much. But if you have someone who's hypertensive, maybe you're gonna push the ARNI first and the MRAs first. So it's gonna be different depending on what patient you have. So once you're done with the 4 pillars, you can add the class 2 recommendations. So ivabradine for patients with their heart rate is not controlled. ARBs is only recommended in patients who do not tolerate ACE inhibitors or ARNI, so they're not a class 1 recommendation anymore. Versigwet is a new medication. I do not expect you to know about it. It was added this year in the guidelines. It reduces cardiovascular mortality and heart failure hospitalization on top of guideline-directed medical therapy. And then digoxin for symptomatic heart failure with AFib when other options do not pan out. And then there is an emphasis on treatment of non-cardiovascular comorbidities. So treating coronary syndromes, treating diabetes, mainly with Sglt2 inhibitors, and treating iron deficiency, which we're gonna hear about in 2 minutes from now. So what about mid-range? So as we said, we cannot make strong recommendations in mid-range, but from studies that were done for patients with preserved ejection fraction and reduced ejection fraction, we can extrapolate that these medications actually could work. And there is no recommendation for patients with preserved ejection fraction, and people were surprised about this because there are some trials that came out that looked at patients with preserved ejection fraction. So I'm gonna show you a couple of them. So the TOPCAT is not a new trial. It's been a while when it came out. It studied spironolactone in patients with preserved ejection fraction. The problem with TOPCAT is there was a difference in outcomes depending on the inclusion center. So patients who were included from Russia and the Republic of Georgia did not show any benefit, but patients who were included from the United States and Canada and Argentina and Brazil showed an improvement in outcome. And this heterogeneity was thought to be related to the diagnosis of heart failure with preserved ejection fraction. So it is part of the ACC recommendation, but it's not part of the European recommendation. I'm just gonna run through the couple that I have. So ARNI, you all heard probably about Paragon heart failure. Paragon heart failure did not show a difference in the primary outcome, but if you counted recurrent heart failure events, it showed a benefit in heart failure with preserved ejection fraction. So that's the reason it was not included in the guidelines. Empagliflozin was studied in heart failure with preserved ejection fraction and showed reduction in the composite endpoint of mortality and hospitalization, but that was driven mainly by hospitalization. The reason Sglt2 inhibitor is not part of the guideline is the guideline was updated in March 2021. So that was before this trial came out, so probably you're gonna see it in the next trial. So this is the summary. Remember to use the 4 pillars of heart failure for patients with reduced ejection fraction, which is ACE inhibitors and ARNI, beta blocker, SGLT2 inhibitors, and MRAs. Make sure to do personalized therapy based on the patient profile. Patients with mildly reduced ejection fraction can benefit from the same therapies as patients with reduced ejection fraction. And patients with preserved ejection fraction could benefit from SGLT2 inhibitors, MRAs, and ARNIs, but they're not part of the guidelines yet, so this is based on your clinical discretion. Thank you very much for listening.
Thank you very much, Dr. Juwairia. It's always interesting to listen to cardiology competing with diabetology about SGLT2 now.